And then when it comes to videos, I let you know you have to play the videos from there. All right, these are my disclosures. I am a consultant to Walk Vascular and to everybody else. So this is the Jedi catheter. It comes in 6 and 8 French outer diameter. The only difference between this device and some of the other ones that you may have seen and used to is that the jet is inside the catheter. There's a suction on the back of the catheter. You'll see it next door. But the jet that breaks the clot is inside the catheter. And that's a differentiator because there is no breakup of the blood clot outside and therefore no hemolysis or hemoglobinuria. And then there's a little thing in the back of it that you plug it in and it works. And so the way, can you play the video please? And so the way it works is that the video please, and the previous one, yeah, this one. So this is just a cartoon of the device. You'll see it working better, and you can see that the jet is actually just inside the catheter. So when you get to the clot, the suction engages the clot, and the breakup of the clot and pulling it in is done by the jet. And so here's the little, little piece of thing that is supposed to demonstrate that, and that's how it pulls the clot in. All right, so everybody's got this, and we all know on the benchtop it works. How does it work in humans? So let me show you that. And the back end of it is like this, and you'll see it next door. So here's a case of a 51-year-old female, 3-day history of extremity swelling, pain, usual DVT patient, and ultrasound positive for iliofemoral DVT. Now I am hugely skeptical of all pharmacomechanical devices. I have not seen one that works in a single session in majority of patients. And the threshold is 80% of the clot in 80% of the patient. And that comes from old literature, actually not that old, back in 2010, from a meta-analysis on how well does catheter-directed thrombolysis work. So you need to reach that. And this was one of them that I said, like, I'll try it and see if it works. I try anything, see if it works. So here's the popliteal approach, and as you can see, there's clot in the femoral vein and the caudal portion of the popliteal vein, and you can see the femoral vein is duplicated, and both of them are clotted, and there is a ton of clot sitting in the common femoral vein and in the external iliac. Okay. Now, the one thing, you guys were just talking about sizing of the veins, and you see a lot of differences of opinions on how you size these veins. That popliteal vein you see right down there, that measures 13 millimeters. Popliteal vein is not 13 millimeter, okay? That's because outflow is obstructed. That common femoral vein, and you see another one like that measured 18 millimeter. I have not seen an 18 millimeter common femoral vein. That's not what you use if you need to stent the iliac, external iliac vein. That's because the flow is obstructed. The veins are compliant. They get larger in diameter when there's no outflow. So keep that in mind as you size these things. All right. So we went up, and as you can see, there's clearly evidence of the common iliac compression and chronic compression over there, but there may or may not be some clot in there. But we know everything below that is acute. So can you play the video on the left side? So we put the device in, and there's some contrast in there so you can see that. And here it is, as you can see, it just pulls everything in. And you could use this device over the wire. It just works a little bit better without the wire, and we put it in an 8-French sheath and we move both of them together. The tip of the catheter is just outside that sheath. That's to basically taper off the tip of the sheath, which can injure the side of the vessel. Can you now look at the video on the right side? That common femoral is full of clot. And now look at that right now. You see how it pulled all the clot in? You just go up there in front of your eyes. You just pulled all the clot in. Now, one of the other advantages of this device is that we just sort of learned by doing. You saw that the femoral vein was duplicated. I didn't go in both of them. I just applied suction into one of the lumens. It pulled the clot out of the other one also. And I'll show you another one where the jugular vein was thrombosed, and we were in the subclavian. Just pulled the clot out of the jugular also. So here it is. Down below, we've made one pass, and the clot is out. And here's the common femoral vein. And the contrast is just sitting there. Note that the saphenous and the profunda also don't have any clot in it. Okay, so everything down below is now free of clot. and the external iliac now, we have applied the device in the external iliac, and that's free of clot. Now we only have the outflow obstruction to deal with, and it's done. So can you play this video, please? And so here's the venogram down. Look at the difference in the size of the vein before and after we pull the clot and outflow. Okay? Some of that may be spasm because we've got a sheath in there. A lot of it is just that it's the vein it's supposed to be. All right. So if you put, here's the other issue about the use of IVUS for sizing. To keep those issues in mind. That is there disease inside the vessel or not? If there isn't, it's okay to leave it alone if you have good flow. Next, and here's the outflow. What the outflow looks like after angioplasty. Of course, that needs to be stented. I didn't stent it at this point just to show we're back to where we were. Okay. Now here's the interesting thing. This is when we started. Look at the time on the film, 10:20 a.m. This is when we finished. Look at the time, 11:38. 1 hour, 10 minutes. I had never been able to do an hour, 10-minute single session DVT from POP to there, reestablishing flow. So I said, maybe I like this device. So I've tried a couple of times more. So we've done a bunch more. And this is the result of the first 19 patients. Not everybody has 30-day outcome yet. Of course, there are a lot of other issues. But as you can see, in terms of performance, the device is supposed to pull the clot out. Of course, you need to reestablish flow because there may be outflow obstruction, there may be inflow problems, all those types of things. In terms of pulling the clot out, at least in our hand, it does very well, better than 90% of the acute clot. This lady is 53-year-old, worsening left upper extremity edema. By the way, tomorrow night there's another program on this, which is sponsored by the Jedi guys. I'll show some arterial cases if anybody's interested also. Today we're just sticking with the DVT. Typical right upper extremity deep vein thrombosis. Our axis usually is in the direction of flow, so we're coming right above the elbow. You could come a little higher also because you got 3 sets of veins in here, and her all were obstructed. So I decided to come very low, so we at least established some inflow into the axillary and subclavian once we open them up. Everything is clotted, so we passed the device once. And here's what you got, just one pass, and you got all the clot to this segment, and now we got the axillary and the subclavian have some clot. One more sort of assessment and pushing, and look, the jugular is thrombosed. In fact, jugular was thrombosed on the ultrasound also ahead of time. And we applied one more suction and pulled the clot right out of that jugular. And now the flow is retrograde in the jugular because brachiocephalic is still occluded. As you can see my wires across the brachiocephalic. It was difficult to get across that brachiocephalic, so I knew there was something chronic in that. And so here's afterwards, we passed the device in the brachiocephalic. There may have been some junk in there that pulled out, but that's clearly a chronic occlusion of the brachiocephalic. Turns out that this patient had an ARDS many years ago, had multiple catheterization, the subclavian veins on both sides. Probably inciting for that, we're not sure. But that clearly needs to get stented, but that's besides the point. The issue is that all of this, and this was done under 20 minutes. From elbow to the subclavian. And I don't know about you guys, but at least in my hands, and I've been doing DVTs since 1995, when most people would say it's blasphemy to do is to put the stents in the iliac veins or anybody else in the veins. And I have not been this successful this quickly in these patients. So it has become now in our acute DVT, I have not tried it in subacute. So I don't know how it would work in the subacute. In acute DVT at least, it seems to be doing okay. All right, so time for hands-on and any more questions you may have next door.